Hello, Vandana.
Hi, good evening.
Yes.
Hi, good
Yes.
evening all.
Good
Yeah.
evening,
Good evening,
sir.
sir. So, Dr. Shalu, we can start the meeting. All the
Sure,
three speakers are joined.
sure. Okay. A very good morning, a very good evening, all of you. Thank you so much for joining this call. I know you guys, everyone has got a very hectic weekend. So, again, I welcome you all for Nubeqa Clinical Conversation 2026. I'm Dr. Shalu, MSL for North Zone. Under this session, basically, we are going to discuss about to understand the treatment landscape for metastatic hormone-sensitive prostate cancer, and discuss various clinical updates in management of MHSPC prostate cancer, and also to gain insights on the evolving scientific narrative for dialutamide doublet and triplet regime in MHSPC and its implications for clinical practice in India. We have with us today our speakers, for starting with Dr. Mintu Matthew Ibrahim. Sir is consultant medical oncologist at PRS Hospital, Trivandrum. Then we have Dr. Mohammad Suhail, senior consultant medical oncology and hemato-oncology at Medanta Hospital, Lucknow. And Dr. Nitin SG, consultant medical oncology, Fortis Vasant Kunj, New Delhi. Now, without further ado, I would like to request Dr. Nitin SG to start the program with the context setting and take the lead. Dr. Nitin SG.
Yeah. Hi, good evening all. Good evening to the support team of Bayers. And thank you for this opportunity. So we are today discussing about the recent updates in treatment of prostate cancer, specifically with respect to advent of newer androgen receptor modulators that we have in market right now. So we all know that prostate cancer treatment have evolved over the years, and from a point of time where we used to treat prostate cancer just by androgen deprivation therapy or surgical castration, we have come a long way. And now we are more stressing on targeted therapies as well as chemotherapy administration, along with um, androgen blockade in this setting of patients. So we know that the main concern for us when a patient is diagnosed with prostate cancer, especially metastatic prostate cancer, is that so at the beginning itself there will be castrate-sensitive prostate cancer, but as time passes and as we progress with treatment, initial line of treatment, the patient have a tendency to go into a castrate-resistant phase. So castration-resistant prostate cancer are quite difficult to treat, and they are often resistant to most of the therapies, conventional therapies. And even though we have got a lot of new researchers, new drugs available, but most of them are not efficient enough to tackle this resistance that develops within the prostate cancer. So the main concern when a patient presents with metastatic prostate cancer is to provide a effective treatment that can prevent or that can delay this progression from a castrate sensitive state to castrate resistant state. So, with the advent of newer generation of androgen blockade therapy, with combination with chemotherapy and even without combination of chemotherapy, we have got very good treatment options available. So, the major advancement was brought about by Bayers with the introduction of darolutamide. So, I have practiced in AIMS and I've studied at AIMS. So, during that time, the population of patient that we usually deal with were those who couldn't afford most of this generation of androgen receptor blockade therapies. But we usually have to resort to abiraterone as well as enzalutamide and all. And many a case, patients who have got cardiac disease or patients who have got compensated CNS status, they all used to have difficulty in tolerating these medicines. So since I got out of the government setup and I've started practicing in private, and I had an opportunity to use darolutamide. And even though I would say, see, we all know that Arasen's data was pretty good considering the overall survival benefit that we got in it. And even Aranaut trial also had shown a very good benefit. But the most important and most striking for me was the quality of life that has been retained with the use of this newer generation drug, darolutamide. So I had a patient who is diabetic, hypertensive, cardiac disease, and he was on darolutamide for almost 1.5 years now, and he's doing great. So the tolerance with this group of medication is very good. So, with the advent of this medicine, I think we are able to offer better treatment options for our patients, especially prostate cancer, who are metastatic. And upfront, we can go either with chemotherapy or without chemotherapy. So, in further sessions today, we'll be discussing the role of this drug, darolutamide, in treatment of metastatic prostate cancer, even in the first line setting, along with chemotherapy, as well as per the error note, without chemotherapy, along with androgen deprivation therapy. We have esteemed faculties involved in this discussion today who are from coming across the country, including the doctors, esteemed faculties from Kerala as well as Lucknow. So without any further ado, I would like to go ahead with the academic session today. And let's have a fruitful discussion. And I'll also be discussing this case, which I mentioned today, and how the patient had responded to this wonderful drug. And yeah, we can have a good discussion. And let's hope at the end of this session, at the end of this 1 hour, we all will be more knowledgeable and more informed about newer therapies that is available for prostate cancer. Over to you.
Thank you so much, Dr. Nitin. That was quite insightful. I would now request Dr. Mintu Matthew to start his presentation and give us wonderful insights. Dr. Mintu, over to you, sir.
Yeah, thank you, Bayer team, for this opportunity, and thanks for the kind introduction. So, is the slides visible?
Yes, sir. It's visible.
So, my topic today is reaching new heights in metastatic hormone-sensitive prostate cancer care. So this is my disclaimer. The slides are presented given by Bayer. So we all know the usual progression or the usual natural history of prostate cancer. We find it sometimes as local or locally advanced or metastatic prostate cancer. The patient may develop biochemical recurrence. Then it may be after ADT, then we name it as CRPC, or before ADT, where it can be divided into HSPC or primary progressive metastatic hormone sensitive prostate cancer. Then we give ADT to those patients, and then all of them become, at one point, all of them become metastatic castration resistant prostate cancer, and go on after further therapies to terminal disease. So basically, the thing is that patients who suffer and die of prostate cancer all have castration resistant disease, because almost none of the prostate cancer patients we are not able to give castration. So that is either androgen deprivation therapy is received by almost all patients, and most of them will die of progression when only it becomes castration resistant. So this is the period that we need to act at most, where we need to be we need to be proactive in treating these patients, so that this period from hormone sensitive to hormone resistant disease can be stalled or can be prolonged as much as possible. So when the disease becomes CRPC, the OS improvement of only 2.5 to 4.5 months have been demonstrated in multiple. So as I said, this is the area where we need to concentrate when we detect hormone sensitive cancer to the journey of hormone resistant cancer. That journey should be prolonged as much as possible with least toxicity. So that should be our aim. There is an opportunity to delay metastatic CRPC and further improve the outcome. So this was first demonstrated by our age-old molecule docetaxel in the STAMPEDE trial, where the OS and the failure-free survival was improved with the addition of docetaxel to hormone androgen deprivation therapy. So from the time where the androgen deprivation therapy was the only treatment till the patients developed castration resistance, this drug gave us time to improvement in the time to CRPC. But now we can do much better. So This is the chart showing the chart showing the Stampede data where the patients were stratified into less than 4 bone metastasis and more than 4 metastasis, where we see that the patients with less than 4 bone metastasis did much better than those with more than 4. That is, in heavy disease burden, the docetaxel, the magnitude of benefit was much lesser. Though the systemic therapy has evolved a lot after this. So from the time where docetaxel was the only drug available, the Chartered and the Stampede trials, to the later Stampede trials where abiraterone prednisolone combination was used. Then enzalutamide, apalutamide, and now darolutamide has also come into the picture, improving the survival. So now we are confused which molecule to use. We have so many molecules to use in this setting. So which should we choose? That is the confusion, and that is what the discussion is about. So going to the Chartered data where docetaxel was used in metastatic hormone sensitive prostate cancer, where it showed that when it is used in high volume disease, docetaxel plus ADT showed a significant improvement in the overall survival with a significant p-value, while in low volume disease it was not much used. That is why the practice is in giving docetaxel is to give it to the patients who have high volume disease, and the low volume disease usually we give ADT alone. That was the practice previously. So then latitude came, which showed that abiraterone, again in high risk metastatic hormone sensitive prostate cancer, the first hormone therapy to show effectiveness in this HSPC high risk patients. But we have to see which patients to give, and we know that it is not an easy drug to give. It has to be continued till progression, unlike docetaxel, which we can stop after a few cycles. But abiraterone, more than abiraterone, the prednisolone part is very difficult to manage long term, especially in the very elderly population who are prostate cancer patients. Even if only 5 mg, the serious adverse events can occur over a long time. That is in the trial, hypertension, hepatotoxicity, hypokalemia, even cardiac issues were much higher in the abiraterone. So then came the Titan trial, where apalutamide was given in metastatic hormone sensitive prostate cancer. Again, it showed that the overall survival and the progression-free survival had significant improvement. Hazard ratio reduced to around 0.48 and 0.65, and the progression-free survival also in even in low volume disease, apalutamide showed some improvement in the progression-free survival. Then ENSUMMIT trial also showed that the enzalutamide addition to ADT showed improvement in the progression-free survival and overall survival. But the subgroup analysis of overall survival showed that it is much improved in the high volume disease than the. So next came the era of combining therapies. We had ADT, then we combined it with either chemo like docetaxel or hormonal agents. Then we thought that why not combine both, so that even much more improvement in survival outcomes can be obtained. That was first demonstrated in the PEACE-1 study design. It was a large trial of 1,173 patients, which included de novo metastatic hormone sensitive prostate cancer, which were given randomized into standard of care plus radiotherapy, standard of care plus abiraterone plus prednisolone, or abiraterone, prednisolone, and radiotherapy. So initial PEACE-1 study didn't include docetaxel. Then as the Stampede and Chartered data came, they included docetaxel as an amendment. So this also showed that there was improvement in the much more improvement in the survival as compared to adding either chemo or hormone therapy alone. But this was also more pronounced in the high volume disease, where obviously we can understand because high volume disease always fails earlier, and addition of therapies would benefit these population. So now coming to our main trial, just the ARASENS study. So the PEACE one, those who are given the PEACE one protocol may know that it is not an easy therapy to administer. That is, the toxicities are significant. So when the trial came, we were all very excited, and we started patients on the study protocol. But most of the patients, I have not till now completed even one patient for the entire treatment protocol. Docetaxel had to be stopped midway, or abiraterone had to be stopped midway, or it had to be sequenced like docetaxel first, then abiraterone. So giving it together is not easy because both these have steroids in their protocol. That is what I think it is the main toxicity component. Docetaxel we have to give pre-medication steroids, and the blood sugars will go all over the place. So the ARASENS study design included 1,300 patients with good performance status, metastatic hormone sensitive prostate cancer, who were candidates for ADT and docetaxel as per their performance status. Were stratified into M1A, M1B, or M1C, and also based on the alkaline phosphatase level. The 1:1 randomization, docetaxel plus darolutamide plus ADT versus placebo plus docetaxel plus ADT. So one arm had darolutamide. The primary endpoint was overall survival. Secondary endpoints were time to castration resistance, time to pain progression, skeletal event-free survival, time to first symptomatic skeletal event, initiation of subsequent antineoplastic therapy, that is failure going to the second line, time to worsening of symptoms, and time to opioid use and safety use. So this is very significant, I feel, because 87% of patients received all 6 cycles of docetaxel, which obviously the trial selected more fit patients, but even in real life, it is not very difficult, I feel, to give docetaxel along with the darolutamide. The overall survival hazard ratio of 0.68 with a p-value of very significant p-value less than 0.001. So this was the comparison between basically docetaxel or docetaxel plus darolutamide. So that is the difference is there, and it is significant. The high-risk patients and the low-risk patients, this we have to, this is important because both the high-risk and the low-risk patients benefited from that, unlike some of the other trials we saw earlier, where even the low-risk patients improved much more than the other trials. The secondary endpoints also showed much improvement. That is, time to castration resistance, 64% risk reduction, significant p-value. Subsequent antineoplastic therapy, 61% risk reduction, significant p-value. Time to pain progression, time to first skeletal event also showed significant reduction with significant p-value. So the PSA response, as we can see in the graph, as the time goes on, the PSA response actually improves with addition in the trial arm. That is 52 weeks. It was patients with undetectable PSA was around 60% and 67% when we calculate the average. So that is, this drug might take some time to act, but definitely detectable PSA, which is the holy grail of this therapy, is achieved over time. More than 2/3 of the patients reached below 0.2. Time to pre-PSA progression also is improved. Overall survival, we know that when the PSA levels are much lower, then the survival is improved. So undetectable PSA at 36 weeks showed better overall survival. So this trial we use as a landmark, and also to prognosticate patients based on their therapy response based on the case. So response and outcome, and when the patient had undetectable PSA level with the darolutamide, the survival is very much rather than with PASI. So darolutamide triplet achieved long periods of no disease progression and also significant improvements to overall survival. So the time to PSA progression also, overall survival also improved. This is the patients with the undetectable PSA levels. In low volume disease, where the other many other drugs have failed to provide this also showed that even better improvement in the undetectable PSA levels, time to PSA progression and overall survival. So deciding between doublet and triplet in HSPC, so patient able to tolerate and accept docetaxel. If we are to consider those patients for the PEACE-1 protocol, then their general health has to be very good. Their diabetes has to be very much controlled. But that part is less strict, I would say, in this protocol. We can give it to more frail patients. Even recently, I had one patient who came from, let's say, he was on this protocol. He is 83 years old. In India, I might not have dared to give this protocol to an 83-year-old, but he tolerated it very well, and he's on darolutamide. So extent of the disease is high volume or risk. Likelihood of hormone insensitive clones is there. Age or life expectancy. So I think this is even more important that our mindset has to change. So in prostate cancer, it is a disease of the very elderly, and we are scared to expose them to multiple agents earlier. Most of us will wait till PSA progresses to expose them to the next line agent. But if the patient is reasonably fit, as we gain experience, we gain more confidence to include them in this triple drug treatment. So that again, as I said, our mindset is that if we give this drug now, we can reserve this drug for the future. So any 80 or 85-year-old are not giving triplet agent, and we are reserving docetaxel for future because we are too scared to give it now. I mean, he may progress in 2 to 3 years. At that time, it will be even more difficult to give docetaxel. So it is much less effective in the post-ARPI progression. So whenever it is possible, docetaxel, if you are planning to give at the earliest. So that is the trial and the data. There are any questions?
Thank you so much, Dr. Mintu. That was quite an insightful session. I would now like to request Dr. Mohammad Suhail to grace his presence and throw some insights on advancing MHSPC treatment horizons, darolutamide without chemotherapy, the ARANOTE evidence. Dr. Mohammad Suhail, over to you, sir.
Okay, am I audible?
Yes, sir, you are audible.
I'm trying to share my slides. Are the slides visible?
No, sir, the screen is not visible, and I think your screen also froze. So you may try.
Can you share the slides from your side?
Yes, sir, I'll try. I'll try. Tech support, if you can confirm the screen is visible.
Yes, ma'am.
Okay, sir, is the screen visible to you?
No. Yes.
Okay.
Yes.
Okay, sir.
Not
So
visible.
shall we begin?
No, it is not visible actually.
So shall we begin? Is if the screen is visible to you? I would like to request tech support to check if something can be done from our end. I'm sharing the screen. If it's visible to the tech support, sir, is it visible to you, Dr. Mohammed? If it's visible to you, the slide, sir. I've shared my screen.
Your screen is visible.
Okay, okay, sir. Sir, so shall we start? Okay.
So, as the previous speaker mentioned, that the more challenging is to treat the metastatic hormone-resistant prostate cancers. So, we want to just delay the progression. So, in that scenario, we basically want the patient to do well, and we want to delay the progression, and we want that resistant thing to come later in the treatment paradigm. So we'll be discussing about Aronote evidence, darolutamide without chemotherapy with ADT.
Sir, I'm changing the slides if it's happening. Please tell me.
Yes.
Slide is not changing.
Slide is not changing. Okay. Let me see.
Hello, ma'am.
Hello.
Yes, ma'am.
The slide is not changing.
Just click and next.
I am clicking on next actually.
Hello, ma'am.
Hello. I am clicking on next actually. It's
फिर से एक बार रीशेयर कीजिए सर slide.
अभी हो रहा है?
नहीं मैम.
Okay, I'll start again. Visible अब हो रहा है?
Yes, yes, no, it is visible.
Okay, sir. Yes, sir.
So, as we all know that the standard of care in metastatic hormone-sensitive prostate cancer it has evolved in due course, and the combination of ADT with AR inhibitors, abiraterone or docetaxel is there. So, starting from 2014, we tried docetaxel with ADT. In 2015, in the Stampede trial, docetaxel with ADT, and in Latitude trial in 2017, abiraterone with ADT, and in Titan, apalutamide with ADT in 2019. So, in due course of time, we can see that there are significant advancements in the therapy. We can see that most of the patient of prostate they are old age patients. So if we can give those patients who are not eligible for docetaxel, ADT or with darolutamide, if we can give some advantage, overall survival advantage and PFS advantage to those patients. And we all know that despite treatment with the androgen receptor blockers and ADT or docetaxel, a large proportion of patients with metastatic hormone-sensitive prostate cancer, they will ultimately progress to metastatic CRPC within approximately 3 years of time. So the unmet therapeutic need of today's is it remains for an effective treatment that offers a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities of chemotherapies and with a low drug-drug interaction potential. So in this, we'll be discussing today. We have ARSENS trial that was a phase 3 study in combination with docetaxel with ADT and darolutamide that already showed beneficial effect and safety profile in the metastatic SSPC patients, leading to its approval in India in 2023. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic HSPC patients, as demonstrated in global phase 3 study Aeronaut trial with significant number of Indian patients in it. And with the Aeronaut data, darolutamide has the potential to change the treatment paradigm, as it would be only androgen receptor inhibitor that which we could be used with and without chemotherapy. So, in background, darolutamide and ADT with docetaxel is a standard of care for metastatic HSPC, as we all know. In our ARSENS trial, darolutamide with ADT and docetaxel demonstrated a favorable efficacy and safety versus ADT and docetaxel alone in patients with metastatic HSPC. So, Aeronaut was designed to evaluate the effectiveness of darolutamide with ADT versus ADT to provide a new treatment option for metastatic HSPC patients who are elderly or frail who cannot tolerate the docetaxel. So it was a randomized placebo-controlled phase 3 study. All histologically proven cases of metastatic hormone-sensitive prostate cancer were taken, who were having ECOG PS of 0 to 2. The stratification factors were visceral metastasis, whether it is present or absent, and whether prior local therapy has been given or not. It was randomized. Patients were randomized in 2:1 fashion. And darolutamide was given 600 mg BD with ADT versus placebo and ADT. The primary endpoint was the progression-free survival, and the secondary endpoint was overall survival, time to initiation of subsequent anti-neoplastic therapy, time to advancement to the CRPC, time to PSA progression, and rates of undetectable PSA. So it was open label study. The selected endpoints were overall survival and safety, and there were 100% crossover was permitted to open label darolutamide. So both the arms were comparable in the demographics. As we can see that Asian patients were 32% with the darolutamide and ADT, and 29% with placebo and ADT. As all the characteristics, they were matched at the baseline. So, coming to the country representation across the breakthrough clinical trial for prostate cancer treatment, as we can see that in Aeronaut trial, the Asian population is around 30% patients are of Asian population. Latin America contributed only 29% patients. Europe and rest of the world, 41% of the patient. In Embark trial, North America 38% patients, and rest of the world 23% of the patients. So region-wise, in China contributed 14.6% patients, India 13.7%, Taiwan 3.4% patients, Australia 4.7%, and New Zealand 2.2% patients. Now coming to the radiological risk of radiological progression or death, darolutamide, as we can see from the graph, which is in favor of darolutamide and ADT, it started separating from very beginning, and it showed that darolutamide with the androgen deprivation therapy, it significantly reduces the chances of radiological prediction or progression or death by 46% versus placebo with a hazard ratio 0.54. Coming to the subgroup analysis of progression-free survival, we can see that in all the subsets, whether age, baseline PSA, ECOG performance status, Gleason score, in all the subgroups, the darolutamide and ADT shows the favorable profile and favors the darolutamide with ADT. All the subgroups were favorable for darolutamide and ADT. So darolutamide and ADT demonstrated benefit across all the secondary endpoints as well, such as OS. We can see that OS, time to metastatic CRPC progression, time to PSA progression. We can see that the hazard ratios favoring the darolutamide with ADT. And all the time of primary analysis OS data are immature, but since OS is immature, patients will be followed for survival, and all the remaining per protocol placebo patients offered crossover to darolutamide after primary analysis. So as we can see from this graph that time to metastatic CRPC progression and time to pain progression, we can see that darolutamide with ADT is favoring the time to metastatic CRPC progression is much more higher. We will compare with the placebo and ADT with the hazard ratio of 0.4 and time to pain progression. We can see that it is favoring the darolutamide with ADT with hazard ratio of 0.72. So delays in time to pain progression, it can be of high importance to patients who have not been demonstrated with other androgen receptor inhibitors till date. This graph is showing that the darolutamide along with ADT it achieved the deep and durable PSA responses. As we can see that 62% of the patients they are achieving PSA less than 0.2 nanogram per ml at any time during the treatment, and time to PSA progression is much better, is much more in the darolutamide ADT arm. We will compare with placebo and ADT arm, where it is 16.8 months, and in darolutamide ADT arm it has not reached yet. So 63% of the patient in darolutamide doublet arm attained PSA less than 0.2 nanogram, and this represented area is the improvement, 69% improvement in time to PSA progression in the darolutamide arm versus ADT alone. So as we can see from this graph, we can see that a higher proportion of patients they achieved undetectable PSA with darolutamide versus placebo in both high volume disease and low volume disease, as we can see from these charts. Coming to the subsequent need of life prolonging anti-cancer therapy, as we can see that the patients who discontinued study treatment were 45% in the darolutamide and ADT arm versus 71% patients in placebo and ADT arm. We can see that patients with subsequent life-prolonging systemic anti-neoplastic therapy, they were only 32% in the darolutamide ADT arm versus 42% patients in placebo and ADT arm. We can also see that docetaxel it was required in 22% of the patients who were being treated with darolutamide and ADT arm, but in 28% of the patients who were treated with only the ADT. We can see that further therapies are needed in much more, many more patients. If we'll compare with the darolutamide and ADT arm in near future. So treatment emergent adverse events, they were similar between the two groups, as we can see, and the discontinuation were lower in the darolutamide arm. We can see that any sort of adverse events, they were 91% with darolutamide and ADT arm, with versus 90% with placebo and ADT arm, and grade 3 and grade 4 adverse events were 30.8% with darolutamide and ADT arm versus 30% in placebo and ADT arm. And grade 5 adverse event were 4.7% darolutamide and ADT arm versus 5.4% in placebo and ADT arm. And any serious adverse events were 23% in darolutamide ADT arm versus placebo and ADT arm, 23%, it was comparable. So, treatment emergent adverse events which leads to permanent discontinuation of darolutamide or placebo, they were 6% with the darolutamide and 9% with the ADT alone arm, favoring the darolutamide and ADT arm. And median treatment duration was 24.2 months in darolutamide arm versus 17.3 months in the placebo arm. And the safety profile of darolutamide in ARROWNET was independent of PSA response, and it was consistent with the favorable tolerability, which was first seen in ARAMIS and ARASENS. Coming to the rates of most common adverse events, they were low and similar between the two treatment arms. As we can see that anemia was reported, the grade 3, grade 4 anemia was reported in 3% patients in darolutamide ADT arm, and in 17% patients, and in 3.6% patients with placebo and ADT arm. Arthralgia was around 1% patients, grade 3, grade 4 in darolutamide arm. UTI in 1.8% patients, back pain 1.8%, constipation 7 in 0% patients, hot flashes 0%, increased ALT in only 2% patients, and fatigue, which is the most important toxicity of the androgen deprivation therapy also. The fatigue was only in 5.6% patients with darolutamide, and in comparison with the ADT alone arm, it was 0.5%. Now, coming to the rates of adverse events commonly associated with the androgen receptor inhibitors, they were similar across the treatment arms. As we can see that hypertension, vasodilation, flushing, diabetes mellitus, hyperglycemia, and all these treatment-related adverse events with the androgen receptor inhibitors, they were similar across the treatment arms. So the question is that darolutamide confers a positive impact on quality of life, and we can see with the help of this graph, which is showing a proper separation from the beginning, that darolutamide with ADT, it is showing time to deterioration is 16.6 months versus placebo, which is 11.5 months. And darolutamide is extending median time to deterioration by score of 5.1 months versus the placebo. And darolutamide is the first and only androgen receptor inhibitor that is demonstrating clinically meaningful delays in overall well-being and pain progression. So here is that darolutamide doublet therapy. It demonstrated the clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptoms domain. As we can see that in this chart, that in comparison with the placebo and ADT, it is a good social family well-being, good functional well-being, and good urinary symptoms control, as we will compare with the placebo and ADT arm, favoring the darolutamide and ADT arm. So to conclude, that we all know that darolutamide and ADT, it significantly improved progression-free survival in patients with metastatic HSPC, as we have seen in this trial. And darolutamide showed a benefit across all the secondary endpoints which we have discussed. Darolutamide was associated with a deeper PSA response, regardless of what was the baseline PSA. Darolutamide is the first and only androgen receptor inhibitor which demonstrated the clinically meaningful delays in pain progression, which improved the overall well-being, including social family well-being, functional well-being, urinary symptoms. And darolutamide had a favorable safety profile, which we usually don't find in other androgen receptor blockers. And darolutamide with ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer patients, especially those patients who are elderly and frail and who cannot tolerate the side effects of docetaxel. Thank you so much.
Thank you so much, sir. That was quite an insightful session. I would now like to request Dr. Nitin for his case presentation. So please, over to you, sir. Sir, you are on mute.
So is the screen visible?
Yes, the screen is visible and you are also audible.
Okay, fine. So yeah, so yet again, so I'm just discussing a case that I actually mentioned earlier, where Nubeqa was used in case of metastatic castration-sensitive prostate cancer. So we have very insightful discussions about the role of darolutamide as well as triplet therapy in the setting of metastatic castration-sensitive prostate cancer, as well as in elderly and frail patients. We also have an option of using darolutamide along with ADT as a doublet therapy, which is also very significant as per the ARANOTE trial, as discussed earlier by Dr. Sohail. So I'll be just briefly discussing a case which I have treated in my clinic. So this was a 76-year-old gentleman who had comorbidities of diabetes, hypertension, and coronary artery disease. So coronary artery disease he had earlier, but it was managed by medical management only. He never got an intervention done, but he was on antiplatelet therapy initially. And diabetes was mostly uncontrolled with HbA1c of around 7 at the time of presentation. And he had two performance status of 2, especially because of the severe fatigue and pain that he had. And he actually presented with generalized weakness. So the clinical presentation initially was the symptoms of lower urinary tract symptoms like increased hesitancy, urgency, inadequate maturation, etc. That was lasting for almost 4 months. He has been evaluated by his local physicians, and there was no conclusion. Later, when he started having severe back pain associated with generalized weakness, he met a urologist, and on further evaluation was found that he had prostate enlargement. So digital rectal examination was done, which showed that prostate was enlarged and hard. PSA was done by the urologist. It was very high in the range of 60.7 nanogram per ml. So the urologist did a biopsy, 12-core biopsy, and the histopathology was consistent with it was consistent with adenocarcinoma of prostate. The Gleason score was 4.5 is equal to 9. So further he underwent a PSMA PET CT scan on 6th of February 2025. There was an increased uptake in the prostate. PSMA avid lesion was there, with the prostatic lesion was infiltrating into the bladder, rectum, and bilateral seminal vesicles. He had multiple PSMA avid nodes throughout the pelvis, retroperitoneum. He also had enlarged nodes which are showing PSMA avidity in cervical region. And the more classic symptom was what he had at presentation was severe back pain as well as headache. And on evaluation, he had extensive PSMA avid skeletal lesions, including multiple vertebrae and skull. So in skull, there was a large lesion which had got a soft tissue component, which was, even though it was extradural, it was more likely to compress to the inwards towards the parenchyma. So a diagnosis of metastatic castration-sensitive prostate cancer was made, and with multiple bone and lymph nodal metastasis. So it was considered as a high-risk disease as well as a high-volume disease. And this patient was initially treated somewhere else, and he was initially started on doublet therapy. And I'm not sure why he was started on doublet therapy. So I just, when he presented to me after 3 cycles, I clearly asked him what was the indication for starting doublet therapy, and was there any particular reason why he was not given any androgen receptor blockade. So, but whatever I could understand, he was just started on immunochemotherapy and androgen deprivation therapy. So as androgen deprivation therapy, they started him on leuprolide, and after leuprolide injection, within after 1 week or so, he was started on injection docetaxel. So palliative RT was given to the skull lesion with soft tissue component because it was quite large, and palliative RT 5 fractions were given to the skull lesion. So he initially received 3 cycles of docetaxel. He tolerated chemotherapy pretty well, but his fatigue was worsening, and he had persistent back pain and persistent symptoms throughout this, and the lower urinary tract symptoms were also persistent throughout the therapy. So at the end of 3 cycles, prostate-specific antigen was done, which was in the range of 18.25. There was a drastic fall in PSA levels, and PSMA PET-CT scan was showing a stable disease, but patient had symptomatically had persistent symptoms, especially with suggestive of back pain as well as headache in the region of the skull where radiation was received. And the lesion in the skull was pretty much of the same size as well as most of the vertebral lesions and nodal disease were at the same are of the same state. So at that point of time, he presented to me and I evaluated him. And since I was planning to start him on triplet therapy, so I advised him for the benefit of triplet therapy, and I was still confused why triplet therapy was not offered to this patient. So, considering his blood sugars were uncontrolled and he was quite symptomatic, I thought of adding darolutamide based on the good benefit that we have seen in ARASENS trial. So, I advised the patient and he started on Nubeqa 600 mg twice daily. So, he was started on Nubeqa from June last of 2025, and the docetaxel infusions were continued as well as ADT was continued. He completed his 8 cycles of therapy, 6 cycles of therapy at the end of August, and a response assessment was done after August. So by this time, patient started showing improvement in his back pain, and he had, even though there was fatigue associated with chemotherapy as well as chemotherapy side effects were persistent, but he started showing improvement in terms of improvement in appetite and general well-being was improving, including the quality of life. So we did a response assessment. The PSA was 0.98 nanogram per ml at that point of time. We repeated a PSMA PET-CT scan in September 2025. As compared to the previous scan, there was marked reduction in size and number of lesions, size and uptake in prostate, as well as there was marked reduction in size and number and PSMA avidity of lesions in bilateral pelvic nodes. And the skull lesion had shown a complete resolution, and there was some significant reduction in size and number of vertebral lesions also. So a partial response was reported, following which patient was continued on ADT as well as TAB Nubeqa. So he, over the time, he slowly started improving, showing improvement in his quality of life. And after almost 2 to 3 months after completion full therapy, he got back into his general normal routines. His quality of life improved markedly, and he started going to do his routine activities. He started going for his evening jogging, and we followed him up through the duration of time. And in January 2026, we repeated a PSMA PET scan, which further showed reduction in bond lesions and the improvement in the PET-CT scan response, and the PSMA was consistently on the lower side with 0.92 nanogram per ml. For the last follow-up was done in May 2026, where a PSMA PET have shown a stable disease, PSA 0.80. The most important point is that his quality of life has markedly improved. He was a diabetic patient with very poor diabetic control. Right now, he has a very good diabetic control. Blood sugars are under control. Hypertension, blood sugar pressure is under control, and he's doing all his routine activities right now. So this was the case that I encountered, and this was the first patient where I used Nubeqa. I'm not saying that the dramatic response, what we saw in this patient, the scans and everything, I'm not showing that it is quite unique for darolutamide. It could have been the same with abiraterone, maybe, I don't know. But the way he has tolerated the therapy, that's what surprised me very much, because I've used abiraterone in patients previously also, but abiraterone chemotherapy combination, as doctor told earlier regarding the ARASENS, when we were discussing ARASENS, he was also he had to interrupt therapy most of the time because of the poor tolerance associated with the combination of abiraterone and docetaxel. But with darolutamide, I never had any issue. He completed 3 cycles, and currently he's having a very good quality of life with only on ADT and darolutamide. So that was my experience using Nubeqa. So the discussion points, what I would like to bring about is, so what is in general your first line of choice when patient have multiple comorbidities? Otherwise, we can always argue, we can always debate whether Arasens or whether it is uh, chartered trial, all these had benefits. So, what should be the first triplet combination? But considering a patient who has got hypertension, diabetes, coronary artery disease, and all these comorbidities and poor quality of poor performance status, I personally feel like if the affordability is not an issue, and if Bayers can bring up more patient assistance program, even with their whatever patient assistance program they are providing, the support is pretty good and patients are able to afford. But still, if we could provide better or more can provide the medicine at a more affordable rate, then it would be quite beneficial for the patient. And my first consideration would be Nubeqa in such a setting. And would you agree to adding Nubeqa after a few cycles of therapy? It's controversial. I don't know whether it was right to add triplet therapy in middle of the cycle, but I think that it could act better if it is given along with chemotherapy, and hence that's what's seen in this patient in my case. And long-term outcomes are we need to wait to see more long-term real-world outcomes associated with use of darolutamide in such a setting. Uh, so any question and answer? I would be like happy to take any question. Hello.
Thank you, sir. Like Dr. Nitin said, anyway, the meeting room is now open for Q&A session and discussion. So I would like to request everyone to engage in the session and discussion. Tech support, please confirm if you are receiving any question in the chat box. I'm not seeing any questions.
Okay, can we go
Not
to
received anything.
Okay. If there
Yes,
are no
Doctor.
questions, oh, sir,
One second, just one
please
question.
proceed. Yes,
So,
sir.
Dr.
Yes.
Nidin, I would like your opinion. So, is there any cutoff age as such which you would be happy with ADT alone till PSA progression, or and we know that the triplet regime is tough to give above 80 or 85 years. But for all patients, would you, if darolutamide option is available, even in 90 or 95 years, would you add it or be happy with the ADT?
Sir, I think that there is no contraindication based on age as such. I think it's all about the patient performance status and how they want to go about it. So definitely chemotherapy wouldn't be a choice in elderly patients, especially I'm a bit skeptical if it is above 70, but in this patient was 76 and still I used it because the patient otherwise had a preserved performance status other than what is induced by the disease as such. So I don't think I would consider any age cutoff as such. In 90 also, I would be happy to use darolutamide. And as per the data, I think it was pretty safe in elderly age as well. I think in the trial also their higher age was, I think 80 something, 82, 85 or something like that.
Yeah, I think so, yes.
Yeah,
Till
so
80.
I'll be happy to use darolutamide. Definitely in an advanced age, I'll be going for doublet therapy. So even with Titan also, see, apalutamide also have a good data when if you compare apalutamide plus ADT in such a setting also, in especially in elderly and frail patient. But yeah, darolutamide, I think it's quite tolerable for any age group that for that matter, even with multiple comorbidities as well. थोड़ा आगे करना है, मैं उतर जाऊंगा. हाँ.
Any other question? I would like to request everyone, if there is any other question, please come forward. I feel there are no other questions. I would like to request Dr. Nitin to summarize the session and give his closing remarks.
Yeah, so thank you, Bayes, for this opportunity. And so it was a wonderful discussion with more insightful sessions we had regarding both the trials which we discussed earlier. And it's really great that you have included medical oncologists from different parts of the country. I mean, within our country, from different parts, so that we could also understand who are there in other parts of the country. We could interact with them as well. So it was an informative session. The only request I would have to Bayer is, yes, if you could actually change the PAP and maybe make it more affordable for patients. So even though it's quite good what you are doing now, but if you could further improve the PAP, maybe we'll be able to offer this wonderful medicine to more patients. But yes, I have become more wiser after this discussion, and I'm sure tomorrow in clinic I'll be definitely thinking about using darolutamide for my patients with metastatic prostate cancer, only considering the patient is affording the medicine. But yes, especially elderly, frail patients, multiple comorbidities, yes, this would be the go-to drug for me. So that's all. Thank you.
Shalu, you're muted.
I'm so sorry. Thank you so much, sir. Thank you so much for insightful session. It was quite a learning experience for me as well. And for everyone attending the session, thank you so much for attending the session, and wish you all a very lovely evening and lovely weekend. Thank you so much, everyone.
Thank you all. Thank you. Good evening.
Thank you.
Thank you. Thank you.
Tech team, we can close the meeting.
Yes, sir.